morning from Miami. This is Dr. John Bennett. We're broadcasting a new series of the daily dose of neurosurgery education. Neurosurgeons hate to be idle, so Iype is going to do hopefully a daily series, and we'll see where it goes. So let's introduce the panelists before we turn it over to Iype. Hello, Warlocks. Warlocks, can you introduce yourself? Go ahead, Warlocks.
Hi. My name is Warlocks. I'm a neurosurgeon from Thailand.
Welcome, Warlocks, and a great artist. Dr. Salek.
Yes. Hello.
Yeah,
Dr.
hi.
Salek from Bangladesh. Yeah, how are you?
Welcome. You're a frequent visitor
okay,
now.
Things are going gloomy here. Corona issues. So I'm here at home.
Yeah, the whole world is getting isolated.
Yeah.
So welcome. Dr. Laguerre. Dr. Laguerre, are you there? Dr. Laguerre, perhaps not. Saad Javed. Saad, are you there? Go ahead. Saad, go ahead.
I'm a neurosurgeon from Pakistan, resident of neurosurgery.
Welcome, Saad.
Pleased to meet you.
Welcome.
Pleasure.
Okay, Khalif.
Good afternoon, everybody from Nairobi. I'm Khalif Abdifatah, neurosurgical trainee, 5th year resident.
Welcome, Khalif.
Glad to be here.
Welcome. Okay, let's see. Ahmed Al Khalif Akhtam, are you there? Or Al Alice Raiba, are you there? Joanna, you're.
Hello, Joan.
Go ahead.
I'm a 5th year medical student from Iraq, and I'm one of the students in Dr. Samer's mentorship program.
Welcome.
It's great to be here.
Welcome.
Thank you.
Welcome. Okay, let's see. Joanna, are you there? Joanna? Go ahead, Joanna.
Hi. Greetings from Finland. My name is Johanna. I'm doing my PhD at the moment and entering in 1 year to subspecialty, doing skull base and tumors now, but my dream is always aneurysms, like you can imagine, because I'm from Finland. So it's sort of like
land of Juha.
Exactly. It's that's how it is usually. Aneurysms and fins, we go together.
Okay, well, welcome, Joanna. Let's see.
Thank you.
Ahmed Mohammed, are you there? And anyone that has it? Okay, go ahead.
Hi, my name is Ahmed. I'm a student, a 4th year medical student in the Royal College of Surgeons in Ireland, and I'm one of Dr. Samer Al-Amri students. And I'm delighted to be here in this lecture today.
Welcome, welcome. Okay, did I miss anybody? Did anybody not get introduced? It's important to network. Okay,
yes.
Go ahead. Yeah, hi. Oh, it's Musindo, I forgot you.
Yes. Hello, I am Augusto Musindo, a neurosurgical resident of Mozambique. I'm doing residence in Maputo Central Hospital.
Welcome, a frequent visitor. Okay, Iype, it's all yours, and welcome.
Hello, everybody. Good to see you on the first daily dose of neurosurgery. That's John's name. I like it. See, the thing is, I wanted this to be a completely informal discussion. And when I mean discussion, I really imply discussion. It's not going to be a delivery class lecture or something like that. It's going to be an interactive program where you guys are going to ask me questions. I'm going to answer you. And it's my job to make all of you in this room understand about our classification, and in that way, all about the carotid in the skull base. Now, I've done this class so many times, so many of you, even John, may have heard it many times, but you know, in this, I would want to stress again that if you want to learn skull base, the most important structure in the skull base is the carotid. You need to be very, very clear about what is the course of the carotid. And unless you're clear, skull base is going to be very vague for you. So I've decided that I'm going to make you do this. I'm not going to precisely deliver a lecture. I'm going to make you do this. All of you, take a pen and a paper. If you cannot take a pen and a paper, take a smartphone or go to the laptop, go into Paint or something. Okay? And when you're ready, you tell me.
Ready.
Okay, ready? All right, let's start. Draw 3 lines, vertical 3 lines, 3 vertical lines. 1, 2, and 3. Okay, draw the first line slightly above, the second line slightly below, and the third line slightly below the second line. So 3 vertical lines in an order where the first line is slightly above, second line like that, and the third line like that. Did we get it? Well, the lines has to be on almost equal, for almost equal. So it shouldn't be like, see, I'm going to show you my chapter. So I'm going to show you 3 lines. First line, second line, third line. Okay? Yes, everybody?
Yes, Professor.
Right. So the first line is in the front. All right, so that's a vertical line. So name it C3. C3. Got it?
Yes.
Did you get it? Everybody?
Yes.
Yes.
You know, I could have used a PowerPoint. I could have used some drawings. But the best thing is your imagination. You know, the best thing. And you must learn to use imagination and visualization. If you don't learn how to use it, you cannot be a good neurosurgeon. Okay? So learn 3 lines. I'm going to paint a picture with my words, and you should understand this picture. So the first line is C3. Behind that line is C5. Behind that, the next line is C7. Did you get it?
Okay.
C5.
Everybody?
C7.
Yes.
Show me, Khalif, show me your lines, please. No, show me please once more.
Go ahead, Khalif. Let me spotlight you.
The right side ones.
Let me feature Khalif on this. How do you do it here? Okay, let's see here. There you go. Okay, let me spotlight. Okay, pin video. Okay, there we go. Okay. Okay, is that correct type there? You see it?
Still, no, you're on the screen, John.
Oh, I'm on the screen? No, okay, let me get myself off the screen. Unpin the video. Okay. Are you back on there, Khalif?
Not yet.
How do I pin you?
Yeah, yes, I can see Khalif's lines.
Okay.
Yeah.
Again, Khalif.
Are they okay?
C3 is on top. C5 is slightly, just the reverse way. Just the reverse way. Can you show your picture again?
Okay.
Everybody should make these mistakes, okay? You see that what you have withdrawn is C3, C5, C7. Just reverse it.
Okay.
On the top one is C3,
Yeah.
C5, and C7. Just reverse it.
C7, C5, C3.
Show me that.
The lower ones.
That is right. So C3 is front, C5 is behind, and C7 is back. Now connect C3 and C5 with a line. Okay, can you connect C3 and C5 with a line? No, the bottom part of C3 and the top part of C5. Okay, go ahead, go ahead. The bottom part of C3. Yes, right. The same way, connect C5 to C7. That is right. You have the carotid right now. Okay.
Let me start the whole thing one more time.
Right.
Right. Hello.
Yes.
Can you show my own?
Okay. Yes,
yes. Please show.
Yeah, let me spotlight you. Okay.
Thanks.
Okay. Yeah. Hold it up there to the camera.
C3.
There we go.
Yeah, hold it to the camera, please.
Yeah. Try it again. For some reason, the camera shot's not going on there.
Can I see that?
Yeah, we can't. I don't know why his photo's coming up rather than his picture.
John, can you pin me up, please?
Yeah, okay. You got it now? You got it? Okay.
Can I see that?
Can everybody see that?
C3?
Yeah.
C5 and C7. He's connected C3 to C5 top and C5 to C7. You have the carotid right now. Okay? Now let me explain. Okay. All right. So the vertical lines, John, can you put Khalif on the screen again?
Yeah, okay, let me try it.
Yeah. Can I see your picture, Khalif?
Can you see it now?
Yeah, there you go.
No? No, you can't see it?
Yes, almost. All right. So this is a very easy way of understanding carotid classification. Let me tell you how. So C3, the vertical C3 in the front is paracellular carotid. The paracellular carotid.
Okay.
All right. C5, just behind, the next vertical segment is paraclival carotid. And behind C5 is C7. That is parapharyngeal carotid, or the vertical petrous, which comes from the neck, goes as vertical petrous, or the ENT guys call it parapharyngeal carotid. So you have parapharyngeal carotid, you have paraclival carotid, and you have paracellular carotid. These are the three vertical segments of extradural carotid. Now, what you connected as C3 to C5, that is paracellular to paraclival, is the horizontal intracavernous segment of the carotid. Horizontal intracavernous segment. Okay? So you have C3, that is paracellular, C4, which is horizontal intracavernous, C5, which is paraclival, and after C5, what segment do you have? C6, which is vertical, which connects C5 to C7. That is the horizontal petrous carotid. And then you have parapharyngeal. Are you getting it, guys? Everybody?
Yes.
No. Yes, Professor.
Are you getting it? Everybody getting it?
You got it, Saad?
Hello.
Yeah, go ahead. Go ahead, Musindo.
Yes.
Everybody?
I would like to know between hello.
Yes, hello, Musindo.
Yes. I would like to know between C5 and C7.
Show me that picture again.
Okay, let me try to spotlight Musindo. Hold on, just give me a second. Where'd he go? Okay. Musindo, I think he dropped off there. Oh, no, there he is. Okay. Okay, there you go. Can you see it? Go ahead, Musindo. Can you show it? Go ahead, Musindo. Can you put it in front of the camera, please?
Yes.
There we go. I don't know if you can see that. Put it close to the camera so we can see it. Well, the resolution is not the greatest.
Cannot really see it, Musindo.
No, yeah, the bandwidth's kind of low. I don't think that'll work with Musindo.
Okay, Musindo has drawn it almost correctly. I can see the outline. He's almost done it correctly. Now, I'm going to show you the actual segments, okay? Guys?
Okay.
I'm going to show you the actual segments. So I'm going to turn my... Right. So, that is C3,
Can you pin?
C5, and C7. So the C3...
Can you put the Iype screen, please? We can't see it clearly.
Oh, okay. You want to see? Okay, let me.
Iype, yeah.
Yeah. Okay. Okay.
Can you see me?
There's not. Hold on, Iype. Hold on, Iype. Let me get the. Okay, I'm having a hard time canceling the spotlight. I'm a rookie. Okay, I'm trying to cancel this. Okay. Hold on, Iype.
Yeah, no problem. Don't worry. Take your time.
Okay, cancel. I think it's okay now.
Yeah, I can see it. You can actually do
everybody
it
see my
yourself.
screen?
Okay, there you go. Okay, I think it's okay now.
Can everybody see my screen?
Yes.
Yeah.
Okay, so that is C3. That is paraclinoid or paracellar. You have C5. That is paraclival. And you have C7. That is parapharyngeal. So you have interconnecting C4, that is horizontal intracavernous, and you have C6, which is petrous. Everybody clear with this idea?
Yes.
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 Okay. Yes.
Everybody?
Yes.
Yes.
We're going to add a few things now. So between C3 and intradural, that is C2, I'm going to add anterior clinoid process. And parallel to C5, that is paraclival, I'm going to add the clivus, and on top of the clivus, I'm going to add the posterior clinoid process. So you have paracellar and paraclinoid carotid C3, C2 intradural, C4 horizontal intracavernous. You have C5, which is paraclival. I have added the clivus also there. You have C6 horizontal petrous and C7 vertical petrous up to here, and then parapharyngeal here. So that's parapharyngeal C7, C6, C5, C4, C3, and intradural C2. You can see that between C4 and C3, I mean, between C4 and C5, you have a small artery coming from here. That is the meningohypophyseal branch of the cavernous carotid. The meningohypophyseal branch gives the artery of Casinari and Bernasconi and the tentorial artery. So this is very important in petroclival meningiomas and tentorial meningiomas. And I will show you later, I will show you where we have gone to the cavernous sinus and clipped off this artery. Okay, to get into the cavernous sinus, I will also show you some other structures which will be of importance here.
Give me a second. Hello?
Yes.
Roshan, avunu milcha. Tapai avunu. नहीं घर में आवनु sir. घर में चलो. Right. We're going to the next picture where I've added one more structure, that is a petrolingual ligament. Okay. So you've got the intradural segment, that is a paracellular or the paraclinoid segment C3. You have C5 paraclival segment. You have C7 parapharyngeal segment. C6 is the horizontal segment, which is intrapetrous. And when the horizontal intrapetrous segment turns to the paraclival segment laterally, there is a ligament, and that ligament is called the petrolingual ligament. You know, there is a nerve which goes along the C6. The C6 turns up to C5, but this nerve goes along, and this is the foramen. What foramen is this? What foramen? Do you know? Anybody who does endoscopic skull-based work, you will be surprised to see that there is a median nerve coming out, and that is marking of which foramen?
Lacerum.
Foramen lacerum. Foramen lacerum is not actually where the carotid comes in. It is the foramen where the C6 turns to become the C5. Okay, the horizontal intrapetrous carotid turns to become the paraclival segment. So the GSPN nerve, which runs almost parallel to C6, it continues on as median nerve, and this median nerve is a marker of foramen lacerum. And laterally, you have the petrolingual ligament. Are you understanding clearly? Yes or no?
Yes.
Yes.
Very clear.
Yes.
Right. So let's get to the next picture now. So we are going to talk about few more nerves. So now, parallel, just inferior to the clinoid, you have two rings. One is the distal dural ring and the proximal dural ring. The distal dural ring is formed by the falciform ligament, comes over the optic nerve, comes over the clinoid, and encircles the carotid there. That is a distal dural ring, and the roof of the cavernous sinus, the actual roof of the cavernous sinus, is the proximal dural ring. So these are two dural rings, and parallel to the C2, or in fact in the cavernous sinus, they enter here. You have the third nerve, fourth nerve. Then you have V1, V2, and V3. So third, fourth, and V1 enter into the superior orbital fissure. V2 enters into the foramen rotundum, and V3 goes to the foramen ovale. Okay, and as I said, the GSPN comes parallel to the C6 and then continues forward at the foramen lacerum, while the horizontal intrapetrous turns to become the C5 carotid or the paraclival carotid. Lateral to the C6, the horizontal intrapetrous segment, you have a tube going from the mastoid or the middle ear to the nasopharynx. What tube is that?
Eustachian tube.
Eustachian tube, absolutely. That is a Eustachian tube. And then behind C7, you have cochlea. So this is why in translab approaches, if you see the cochlea behind the cochlea is your facial nerve, is your IAM, is your semicircular canals, all that is okay. But when you see cochlea, you should know that just anterior to the cochlea is your parapharyngeal carotid. So you have cochlea there, you have Eustachian tube there, you have GSPN continuing as median there, you have the petrolingual ligament lateral to the carotid, lateral to the carotid C6, C5 junction, you have the Gazerian ganglion, you have V3, V2, V1, you have cranial nerve 3, 4. And by the way, just medial to V1 is your cranial nerve 6. Okay, the cranial nerve 6 is just medial to V1. So you have, now we are reconstructing things around this skeleton. Okay?
Okay.
Let's see now. In the real picture, you have C2 intradural, you have C3 there. So you have the third nerve coming in there. So C3 is there. C4 is going to be like that, and C5 is there, and then C6 will be intrapetrous. Okay, horizontal. So you have V1, V2, V3 Gazerian ganglion here, third nerve here, proximal dural ring, distal dural ring, all these things you have, okay? And the clinoid has been taken out. So you can watch our videos again on the, there is another video. If you type Iype, Cherian, and Dolink, you will get another video, one of my lectures in Russia, and you can watch that, and then you can reiterate on what I just said. Also, Narayan Janaki Ram's textbook chapter. This is the textbook. I can send it on a PDF to you guys. Any one of you who is in the group, in the WhatsApp group, I can otherwise add you to this WhatsApp group where we share all these academic things, and you can see this chapter. This chapter also has a video. Maybe what I can do is you can take a photograph of this scan. You can take a photograph of this scan and you can go to that video directly. You can go to this video directly and you can see the video of this approach. And you'll be able to, if you scan it, you'll be able to get into it. And that place also has the website. Okay, so you can go into this website and you can see this video. And if you see this video, you'll be able to get into that approach where you can see each and every part of this dissection. Thank you very much for today. And if you have any questions, send it on WhatsApp to me. I'll try and answer you. Thank you very much.
Oh, thank you. Thank you so much, Prof. Thank you so much. We really appreciate this. Before we move to questions, I just wanted to, John, if I can do some screen sharing.
Sure, go ahead.
And then just two questions related to the topic of today.
Yes.
Okay.
Oh, why is it having issues? Yeah. So let me try again. Yeah, this is just what we were discussing.
Yes.
You can see the question?
Yes, tentorial artery. Mm-hmm.
Yeah, so we take 60 seconds to answer the questions. It was just
so
mentioned
by... Can you tell me now that you know what is that brand?
Yes.
That is, can you tell me? What is the answer?
It will be in C4.
Yes, between C4 and C5, that is cavernous, right?
Cavernous,
so C4,
yes. So
C5, and C3 is cavernous, all right?
Yeah.
So it is just not only cavernous. Cavernous is very non-specific. You have to, it is the top of C4, horizontal intracavernous segment, and the junction of the horizontal intracavernous with the paraclival. Okay.
With the paraclival.
That is where,
yes. Yep.
Yeah. So that is where it is cavernous. It is, of course, it is cavernous. And
so of course
that is where the yes.
So the classification is a little different.
Don't worry about any classification. Just follow this classification. Okay. All these classifications are very, very confusing.
Okay.
So you learn that C3, C5, C7. C3 is C3 is paracellular, C5 is paraclival, C7 is parapharyngeal. So this is Fisher's classification, modification of Fisher's classification by me. It is most easy. There is no need to worry about it, and you can build the whole skull base around it. So no need to worry about any other classification. If anybody asks you about classification, this is published. This is published in a textbook, so you can clearly go ahead and quote it. I haven't named it as Cherian's classification, but you can say that it's a modification of Fisher's classification.
Perfect. So this is one of the past paper from one of the European exams in the past years.
Yeah.
And so the answer is, as you said, is the cavernous part. So the segments. Now in your case, it's reverse. In your classification, I felt like it's reverse of this
Yes, absolutely.
classification. Okay. So and what they wanted us to know is the different parts of the ICA has different. Some segments have arteries, some don't have any arteries. So it's the cavernous part, and the tentorial artery originates from the meningiohypophyseal trunk, which is in the cavernous part of the ICA. So these are just one of the questions I was trying to present after the presentation. And the meningiohypophyseal trunk has these branches as well. It gives over inferior hypophyseal artery to the pituitary. It gives the one you mentioned, and this is the one they want, Bernasconi artery, which is also called the tentorial artery. And then the lateral
you must
tentorial
understand
artery
that.
and the clavicle.
You must understand that one is constant, that is the inferior hypophyseal artery is almost constant. 2, 3, 4 are very small branches usually, and they become big only if there is a pathology.
Okay, so the pathology makes the artery become bigger.
Yeah, so I have seen artery of Bernasconi and Casanari, really big arteries of Bernasconi and Casanari. When we do petroclavial meningiomas or tentorial meningiomas, or sometimes if there is a DAVF involving the superior petrosal sinus, sometimes this is supplied by this branch. So in that case, these branches become big, otherwise they don't. So these are very small branches usually.
And we usually don't see them in a DSA.
It's difficult to see them. Well, you can see them if you look for them. Maybe you can, but it's difficult to see them.
Yeah. So the artery we're discussing is the tentorial artery, which is a branch of the hypophyseal trunk and is labeled at C in this model. So the answer will be the cavernous part. So one more question. This one here, you can take 30 seconds to read it.
See, in this case, you must understand a little bit about the third nerve. Okay, I thought we can discuss the third nerve on another class if you want. I can discuss the localization of lesions of the third nerve with respect to vascular territories, as well as, say, for example, how will you identify a nuclear third nerve palsy? How will you identify if the third nerve is involved in the fasciculi in the midbrain? So there are many third nerve fasciculi. Before they become the third nerve, these fasciculi, they go through the midbrain peduncle. So if the midbrain peduncle also has the corticospinal tract, so you have ipsilateral third nerve palsy and contralateral hemiparesis. This is known by a very classical syndrome. Everybody will know this syndrome. Anybody? Weber's syndrome. Okay.
Weber's syndrome. Okay.
Yeah. So you have third nerve fascicles getting involved. Nuclear third nerve, bilateral ptosis would be there. Bilateral ptosis. This is a classical feature, and I can explain how this happens. On the other hand, third nerve fasciculi getting involved, you can have involvement of the midbrain peduncle also. This involves hemiparesis on one side. Okay, and then in the subarachnoid space, the third nerve is between the superior cerebellar artery and the posterior P1. So aneurysms at the P1 and superior cerebellar artery, these are very, very rare. They can cause third nerve palsy, or the third nerve goes along parallel to the PCOM, so you can have a PCOM aneurysm and then you can have a third nerve palsy. We recently had a patient who had a third nerve palsy like that. And then the third nerve goes, so inside the cavernous sinus, if there is a third nerve palsy, you can have involvement of 3, 4, and 6 generally. So a third nerve palsy completely involving 3, 4, 6 with a frozen eye is a cavernous segment. Sometimes you can have a third nerve palsy inside the globe. So what happens in the globe, you have a superior branch and an inferior branch. So sometimes only partial third nerve palsy is there. So you have to differentiate it, of course, from a nuclear third nerve, but otherwise you can classify the third nerve palsy into the superior and inferior branch. Okay, so you have to see what levator palpebrae superior is involved or not. So that will be the superior branch and then the inferior branch. So you can localize the third nerve in the nuclear part. You can localize it at the fascicles. You can localize it in the subarachnoid space where it is in the interpeduncular space. You can localize it in the subarachnoid space where it is medial to the temporal lobe. That is why when temporal lobe herniation happens, you can have third nerve palsy. You can have it when you have a PCOM aneurysm. You can have it in the intracavernous segment. You can have it in the superior orbital fissure, and you can have it inside the globe. So all these is localization for the third nerve. And you should also understand that the sympathetic fibers are carried in the superolateral part of the third nerve. That is why when there is a herniation, you will have only this part. So pupillary dilatation happens first, and then the complete third nerve palsy happens. And the vascular supply of this third nerve is also different. So that is why in medical third nerve palsy versus surgical third nerve palsy happens. You should read this up. Okay. So this is homework for you since you gave this question. Of course, the answer is posterior communicating artery. You should also know the localization of the third nerve with respect to different places. Okay. You must always understand that.
Thank you so much, Prof.
No problem. You must always understand that a neurosurgeon is a surgical neurologist. So you must very, very clearly know how to localize lesions. Okay.
Yeah. Exactly. So this question was testing, as you clearly indicated. We needed to know the cause of the third nerve and the nerve components and the organization of the fibers. And as you said it, the parasympathetic fibers are the ones that control the pupillary dilatation, and they are located in the dorsal superficial aspect of the nerve. So that's why the rest of the palsy is preceded by the parasympathetic component, and that can happen only if the lesion is in the subarachnoid space, as you said it. So thank you for the very clear explanation. If it's medical, as you said, it's usually nuclear level, and it's seen in diabetic neuropathies, atherosclerosis, pathologies related to vascular and autoimmune that will cause a nuclear pathology. This is the cavernous.
That is because the supralateral part of the third nerve is supplied by the meningeal arteries, and these don't get involved in medical conditions. And while the other part of the third nerve gets involved in medical conditions, and this is why it is pupillary sparing palsy.
Yeah. So thank you very much for that good explanation. This is what is causing this gentleman's palsy. It's posterior communicating artery aneurysm, which is almost in all cases pointing laterally and inferiorly. Remember, the PCOM is located medially and superiorly to the third nerve. So when there is an expansion of an aneurysm of the PCOM, it usually causes third nerve palsy. And in this case, the fibers that are affected initially are as Prof has explained, the parasympathetic parasympathetic fibers. So the answer is, of course, we've already been told, is the PCOM aneurysm.
Excellent.
Yeah.
Excellent.
Thank you
and
so much. Yeah.
in fact, I operated on one of these cases, and I showed it on Neurosurgery TV maybe 2 or 3 weeks ago, and I had to go and I had to cut the tent because this aneurysm was inferior to the tent. This PCOM was inferior to the tent, so it is a ruptured aneurysm. So I had to cut the tent and very slowly, and then identify the third nerve, identify the PCOM, and then clip it. I'm sure it is. This video is in the archives, so you can see that it'll become much more clearer to you. So we will keep on doing this. I'm really enjoying this discussion, and I hope Samar comes and talks something about this case or something that he was going to discuss. Samir, I will not take up time anymore, so please go ahead and discuss, please.
I'm ready, thank you. Can I comment on the last figure, please, Dr. Abdul Fattah?
Yes, please. You want me to share the screen again?
The PCOM aneurysm compressing the third nerve?
Yes. Yes.
The figure.
Okay.
Yes.
On here.
Yes, I'm just commenting on that. This is not the common PCOM aneurysm, because the PCOM aneurysm is the commonly originated from the antenna carotid just beside the origin of posterior communicating artery. Here, it's a rare form called a pure or a true PCOM aneurysm, where the aneurysm originated from the posterior communicating branch. Do you get the idea?
Yeah.
I think it's not under focus of the topic or while illustrating this figure, but this is not the common PCOM. The common PCOM originated from the ICA, from the antenna carotid artery, and here
proximal to the origin of the PCOM.
It's beside the origin, but it's ICA aneurysm. It's not a pure PCOM aneurysm. In this figure, it's a rare form called a pure PCOM aneurysm or true PCOM aneurysm, where the aneurysm originated from the posterior communicating artery rather than from the antenna carotid artery.
Thank you.
Okay.